Welcome everyone to tonight's webinar, Managing Hepatitis B in General Practice. My name is Serena, your RCGP representative for this evening. We are joined tonight by presenters Dr. Tao Lam and Dr. Brendan Wall. Before we get started, I would like to make acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders past, present, and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I'd like to introduce you to our presenter for this evening. Dr. Wong graduated from the University of Sydney and is a fellow of the RCGP. Dr. Wong enjoys all aspects of general practice, in particular pediatric, men's health, dermatology, and sexual health. Dr. Lam is a clinical advisor and has extensive experience presenting at ASHM training and has involved in development of most of the HCV course materials. I'll now hand it over to Brendan, who will go over the learning objectives.
Sorry, hello everyone. Thank you for coming. Our learning objectives for tonight, as you can see, essentially to identify when hepatitis B testing and vaccination is needed for at-risk people, to describe the primary care role in diagnosing, monitoring, and managing chronic hepatitis B, and using the hepatitis B referral pathways and clinical support tools to support safe and effective patient management.
Hepatitis B prescribers will receive 1 prescriber point for full attendance of this course. There is more information on how to accrue this point at the end of the webinar, so stay for that. And I'll hand over to Tao to continue with the rest of this session.
Okay, so I might start off looking at the how big the problem is with hepatitis B. So next slide. So it's estimated that about 254 million people living with chronic hepatitis B in 2022, and about 1.2 million new infections are presenting each year. The highest prevalence is actually seen in Western Pacific region, the African region, and Southeast Asian region. This actually is really important information to know, because it may be the cohort of patients that you would see coming through your rooms, and it may be a prompt to ask them about their hepatitis B status and to suggest that they screen for it. Hepatitis B results in about 1.1 million deaths each year, mainly from cirrhosis and hepatocellular carcinoma or primary liver cancer. In fact, hepatitis B is the #1 cause of liver cancer. It is preventable disease. Next slide, please. So when we look at the hepatitis B in Australia, there's just under 220,000 people living with chronic hepatitis B, of which about 78,000 people in New South Wales. And when we look at this pie graph, looking at the priority group, you can see that almost 50% of the priority population come from East Asia. This is then followed by Aboriginal and Torres Strait Islanders. You also see people coming from North Africa, the Middle East, Southern and Eastern Europe as well. Next slide. So the key point is that hepatitis B is a worldwide issue. A majority of people living with chronic hepatitis B in Australia are migrant from high prevalence areas, particularly Asia and the Pacific. Aboriginal and Torres Strait Islanders Australians are also a priority population with a high prevalence of chronic hepatitis B. Next slide. Why do we need to worry about hepatitis B? Next slide. Because it's the most common cause of liver cancer worldwide, as I mentioned before, the risk of developing liver cancer is actually 20 to 100 times higher in people living with chronic hepatitis B relative to those without infection. And in fact, you can develop liver cancer without having cirrhosis if you have chronic hepatitis B infection. Next slide. So this is looking at the natural history of chronic hepatitis B. For people living with chronic hepatitis B infection, about up to 40% have a risk of developing more advanced disease, that is cirrhosis, that can lead to liver failure and liver cancer. But I think what I want to stress is that for most people with chronic liver disease, cancer develops in people who have advanced disease with cirrhosis. But in hepatitis B, because the virus is an oncogenic virus, you can get the hepatitis B at a younger age and without cirrhosis. Next slide. So let's have a look at transmission and how to prevent it. Next slide. So transmission occurs perinatally or through early child contact, parenterally or percutaneously and sexually. In Australia, most acute hepatitis B infections are due to sexual transmission or sharing of injection drug equipment. Most chronic hepatitis B infection are due to perinatal transmission or exposure in early childhood. It's important to note that kissing, hugging, sharing food, drink, cutlery is not a risk for hepatitis B transmission. Next slide, please. Let's go to our first quiz. What's the likelihood a baby infected with hepatitis B will go on to developing chronic infection? Can we start the poll, please? Okay. Can we see how what the answers are? Okay, a bit of a mix. Let's go. Let's have a look at this question in the next couple of slides. Next slide, please. So you can see there that actually the age of exposure to the hepatitis B virus is really important in terms of the risk for developing chronic infection and disease. So for a baby or an infant that was exposed peritonially, you almost have an 80 to 90% chance of developing chronic hepatitis B, whereas as an adult, it's less than 5%. And childhood, it is about up to 30%. Next slide. The highest risk in terms of exposure through blood and serum for someone who has chronic hepatitis B infection. You can see there, the most important thing is that breast milk, the risk is very low. So it's very important for mothers who have hepatitis B, they should be encouraged to breastfeed their baby. Next slide, please. Also, I think this is a really important slide because it informs us that who is able to get the hepatitis B virus vaccine for free. So under the Commonwealth funded program, it's anyone who's age under 10 years old, and there's also catch-up vaccination for people who are 10 to under 20 years old. Refugees and humanitarian entrants aged 20 years and over are entitled to getting a free hepatitis B vaccine. In addition, New South Wales government has also provided free vaccine for priority groups. So you can see there Aboriginal and Torres Strait Islander Australians, household and sexual contact with acute and chronic hepatitis B cases, people who are immune compromised, including those who are undergoing chemotherapy, cancer treatment, people with HIV or Hep C co-infection, men who have sex with men, injecting drug users, sex workers, clients of sexual health clinics. That's at the discretion of the actual individual LHD. Adults who with chronic kidney disease or undergoing hemodialysis or pre-dialysis patient. Also bone marrow transplant recipient aged 10 years and over. So it's important to remember this because I think that these are high priority groups, but also they come from disadvantaged or marginalised community and may not prioritise vaccination because of costs. It's very important to stress that hepatitis B is a vaccine preventable disease, and vaccination is the most important weapon we have against developing hepatitis B related liver cancer. Next slide, please. So the key points to note from transmission and prevention of hepatitis B that most people living with chronic hepatitis B in Australia acquired the infection at birth or in early childhood overseas. Most acute infection in Australia due to sexual transmission or unsafe injecting drug use. Vaccination in New South Wales for free for people that are household sexual contact, Aboriginal and neonates, and other groups at high risk that I've spoken before. Clinicians really play an important role in prevention, that is promoting and providing vaccination, promoting harm immunisation strategy, such as referral to needle and syringe programs or opiate treatment program. Next slide. Okay. Looking at testing and interpreting results. Next slide.
Sorry, so this is my
Yeah,
part
this
now.
is
Oh, sorry. So I'm going to be talking about testing and interpreting results of hepatitis B. So before I start, one of the important things to note is recording Aboriginal and Torres Strait Islander status. I guess all of you who work as general practitioners probably do this anyway. What I like to do is normally just go over there if they're a new patient, or if they're a new patient to me, just ask them, do you identify as Aboriginal and Torres Strait Islander? So this question must be asked of all patients and students, regardless of appearance or background, explained as relevant to care and service planning, due to the fact that Aboriginal and Torres Strait Islanders are at risk of developing chronic hepatitis B, and accurately record this in their patient record. Why this matters: so it supports clinically appropriate care, promotes culturally safe service delivery, enables accurate reporting, monitoring, and resource allocation, and required for all New South Wales health services. Next slide, please. So I think as general practitioners, one of the hardest parts of our job is knowing where to find all the information and knowing how to implement it. So ASHM have created a very useful tool in order to help you decide how to manage patients with chronic hepatitis B. So to use the decision-making hepatitis B tool, and it can help you understand when to test and who to test, what diagnostic tests need to be ordered, how to interpret serology, what assessments to perform if someone is hepatitis B surface antigen positive, how to assess the phase of the infection, how to provide ongoing monitoring, including hepatocellular carcinoma surveillance, and when to refer to a specialist. As you can see on the slide, this tool was developed by ASHM, and it can be found on the ASHM website. Next slide, please. So when to test is an important part of the decision. Sorry, can you hear me any better?
Yeah.
Okay, sorry, apologies. I'll try to speak really close to my speaker. So the following people should be offered testing. So on the decision-making in hepatitis B tool, that's the first number on the tool, so number 1. So essentially people born in intermediate or high prevalence countries, as Tao was suggesting. In where I work, especially South Asian and Asian people and men who have sex with men form a large cohort of my patients. So I do offer and test a lot of people for hepatitis B. Aboriginal and Torres Strait Islander people, so referencing the slide previous, it's very important to know if someone identifies as Aboriginal and Torres Strait Islander. Patients undergoing chemotherapy or immunosuppressive therapy, pregnant women, infants and children born to mothers who have hepatitis B for more than 9 months, people with clinical presentation of liver disease, elevated LFTs of unknown etiology, health professionals who perform exposure-prone procedures, partners, household, and sexual contacts of people with acute or chronic hepatitis B infection, people who have ever injected drugs, men who have sex with men, people with multiple sexual partners, people in custodial settings, other co-infections such as HIV, hepatitis C, or both, patients undergoing dialysis, sex workers, people initiating HIV pre-exposure prophylaxis, otherwise known as PrEP. Part of asking or bringing up testing for hepatitis B is to reduce stigma and discrimination in regards to testing and ongoing treatment. Next slide, please. The next part is how to test for chronic hepatitis B. So it requires 3 tests. You may be familiar with this or have seen something like this before. I remember in my medical student days, these were always good multiple choice questions. So, but you basically need to test for hepatitis B surface antigen, hepatitis B core antibody, and hepatitis B surface antibody. If acute hepatitis B is suspected, then you can also order hepatitis B core IgM. But make sure that you order the 3 tests, so hepatitis B surface antigen, hepatitis B core antibody, and hepatitis B surface antibody, in order to determine someone's hepatitis B status. You can set this up as a favorite in your whatever medical software you have when requesting for hepatitis B test. Next slide, please. So essentially, interpreting serology, depending on whether someone is hepatitis B surface antibody positive or negative, hepatitis B core antibody positive or negative, and hepatitis B surface antibody positive negative, will then assist you in determining whether or not they have chronic hepatitis B, whether or not they're immune, whether or not they may have a resolved infection. So essentially, the interpretation of the different serologies will assist you in understanding someone's hepatitis B status. This takes some time to review, but just the tool will help you decide someone's hepatitis B status based on the results. Next slide, please. So the key points of testing and interpreting results. So opportunistically test patients from priority groups. Order all 3 serological tests. Very important to write query chronic hepatitis B if you believe someone may have chronic hepatitis B. I don't know what labs you guys have, but depending on what lab you order through, if you write hepatitis B serology, what normally comes back is the hepatitis B surface antigen result, which may help tell you if someone has a hepatitis B infection, but it doesn't tell you about their immunity status or anything else like that. So very important to write query chronic hepatitis B if you don't know what the tests are, and then you'll get all of those 3 serological tests returned to you. Next slide, please. I believe now this is
this is where I jump in.
Yep.
Yeah. So if your patient has hepatitis B, what do you do? Next slide, please. So the initial assessment includes the following. Always request the hepatitis B E antigen and the anti-B antibody, and the quantitative hepatitis B DNA or PCR, because this allows us to, as well as the liver test, because this allows us to assess the phase of the disease that the patient is in, and informs us as to who may be eligible for treatment. I also actually would include electrolyte and renal function, because renal function does play a part in which antiviral you may use, and also you may need to adjust the actual dose of the antiviral. Alpha fetoprotein is always good to do at baseline, As I said, people don't need to have cirrhosis to have developed liver cancer. I also include a normal ultrasound because this tells us the structure of the liver disease that may give us evidence of portal hypertension as well. I think in addition to that, you may assess the stage of the liver disease by ordering some tests that we'll talk about a little bit later. In addition, I also asked for hepatitis A, IgG. While hepatitis A does not cause chronic liver disease, it is important to note that 10% of people with acute hepatitis A may develop prominent liver failure. If you've already got a liver disease, it increases this risk. So it's really for all vaccination purposes. I'd asked for a hepatitis C antibody. If you know someone that's actually had hepatitis C treatment previously, then I would order a qualitative hepatitis C RNA level. It's important to also look and test for hepatitis D or Delta virus as well as HIV. The other thing I would note is assessing people for other cofactors that may affect their progression of the liver disease, such as the use of alcohol, metabolic risk factors, in particular metabolic syndrome, diabetes, obesity, because these people have increased risk of more progressive disease. Also screen household contact and sexual partners or people with chronic hepatitis B, using the 3 serology tests that Brendan had mentioned. Offer vaccination to all high-risk groups, and most of which is provided for free in many cases. So you can contact your local health department for detail. Next slide, please. Let's have a look at the first case. So Chen is a 54-year-old Chinese man living in Australia with his wife and 2 kids for the last 10 years. He presented following a recent trip back to China to attend his father's funeral, who had died of a liver tumour. Chen was diagnosed with hepatitis B in China as a student and was told that he was a healthy carrier. Hence, he had not had any follow-up for his hepatitis B. The recent death of his father has made him worried about his liver. Next slide. We're going to go to quiz question 2. You want to understand his hepatitis B status? What tests should you order? Will you see the poll result, please? Great, it's great to see that majority of people actually chose an option A, which is true. Even though he was diagnosed in his when he was younger, we're seeing him for the first time, so we should actually treat it as an initial assessment. Next slide, please. So these are a summary of the results of Chen's initial assessment. So he is positive for hepatitis B antigen. He's negative for the anti-BE antigen. His viral load is 10,890 international units per mil. He had an ALT 50 units per litre. So this is raised. So our new normal for women is less than 20, for man is less than 30. 3 months later, his ALT results show that the ALT is increased to 55. Next slide. So quiz number 3, which phase of disease is Chen currently in? We see the poll results. That's right, A is the correct answer. Next slide, please. And we'll look into this a little bit more closely. So this is a very important slide. It's been very busy, but it's good for everyone to understand that the importance of this slide. So we're looking at the phases of chronic hepatitis B infection, and I'm also going to remind everyone the new terminology to use now. In the past, we used phase 1 as being immune tolerant, immune clearance, immune control, or inactive carrier, which no longer should be a term that you should be using at all. Phase 4 is immune escape, and phase 5 is when the person has resolved infection. The new terminology now to use is phase 1 is hepatitis E antigen positive chronic hepatitis B infection, and this is where there is high viral activity with very high viral load. Usually, it could be greater than 10 million international units per mil. However, the ALT is actually normal, and people in this phase have none or minimal risk of liver disease progression untreated. So in this phase, treatment is not required, but there are circumstances where you may consider treating these people, and one is actually pregnant women. So phase 2 is where a person had E antigen positive chronic hepatitis B. Here, the virus is becoming is active. It's also now activating the immune system. So you see here that the viral load is moderate to high levels, and there's also now a rise in the ALT. We talk about the ALT because it's specifically produced by the hepatocyte and really reflects injury to the hepatocytes. So there is moderate to severe risk of liver disease progression if left untreated. So these people be assessed for treatment. And that could be with yourself in the community, or if there are other reasons, a referral to a specialist. So phase 3 is immune control. This is a person who had E antigen negative chronic hepatitis B infection. So here, the immune system is beginning to control the viral activity. So you'll see that the hepatitis B DNA levels will start to fall, often below 2,000 international units per mil. The ALT begins to normalize as well. There is little or no risk of liver disease progression. So treatment isn't required during this phase. Phase 4 is hepatitis E antigen negative chronic hepatitis B, and this is now where you can see increase in viral activity with a rising hepatitis B DNA level. The ALT is persistently elevated or intermittently fluctuating over time. There is mild to severe risk of liver disease progression. So this is the phase that we would also treat people as well. Phase 5 is resolved infection. So this is where you can see in your serology the loss of surface antigen, even better if it is development of surface antibody. So the DNA, the hepatitis, the DNA undetected below the level of detection for our test assay, but you can still detect cyclical DNA in the hepatocytes themselves. Hence, we say that hepatitis B infection is not curable without treatment at this stage. The ALT is usually normal. There's no risk of liver disease progression. Treatment not required in this phase. However, some people will need to continue with their liver cancer screening. People can move through these phases back and forth. Hence, it's important for patients with chronic hepatitis B to be regularly evaluated to determine which phase they're in and to be managed accordingly. Next slide. Before I go, this shows us that Chen is currently in phase 2, which is the E antigen positive chronic hepatitis B. So he should be considered for treatment. Next slide. The key point that there's no such thing as a healthy carrier. Chronic hepatitis B is a dynamic disease. So patients can move between phases. It can be years. It can take years to be moving between different phases, but it's always important to monitor patients regularly. Initial assessment of patients who are surface antigen positive should determine the phase of the infection. Patients should be followed up with offers and suggestions for social support and resources after diagnosis. Next slide. So this is Brendan.
Yep.
Apology. So this slide essentially differentiates or tells us the differences between GP and tertiary-based specialist care. So just be aware, as GPs, we can monitor patients with chronic hepatitis B, essentially those patients who are phase 1. So hepatitis B antigen positive chronic infection or immune tolerance. And then also those.
Oh, sorry to interrupt. If we don't mind changing the speaker a little bit, I think it's
Okay.
yeah. Thank you.
Is that any better, or is that worse?
I think so.
Better?
Yeah.
Okay, sure. Sorry. So GPs can monitor patients in phase 1 and also those in phase 3. So hepatitis B E antigen negative chronic infection, so immune control. Those that are in phase 1, so phase 2 and phase 4 should be considered for referral to an S1 prescriber or to a tertiary-based hospital specialist for consideration of treatment to reduce the progression to cirrhosis and hepatocellular carcinoma. Next slide, please. Sorry, Serena, I'm just going to unplug my speaker and see if that's any better for me. Is that any better for you guys?
Much better.
Okay, sorry. It's probably my old headphones. Okay, I apologize for that. Hopefully you don't get any other background noise that comes through. So monitoring and treatment. Now we discuss monitoring and treatment of those with chronic hepatitis B. So next slide, please. Okay, so you established that Chen is in hepatitis B E antigen positive. Chronic hepatitis, so immune clearance. Should he be considered for antiviral treatment?
Shall we see the results?
Yes, please. Yes, so Chen is in immune clearance, so he should be considered for antiviral treatment. The answer is yes. So we can prevent hepatocellular carcinoma from occurring with regular monitoring, healthy lifestyle changes, and treatment if needed. So essentially our role as GPs is vital in limiting the risk of liver cancer in patients with chronic hepatitis B infection. Next slide, please. So this should be fairly familiar to most of us as general practitioners. So people with chronic hepatitis B should obviously eat a healthy diet. I guess minimize takeaway foods. Try aim for about 5 serves of vegetables a day, 2 serves of fruit. In terms of alcohol, drinking alcohol can make any liver disease worse. So we normally advise no alcohol consumption. Vaccination against other infections that can also impact the liver. So, for example, hepatitis A vaccination, if not vaccinated already. Patients with chronic hepatitis B should see their doctor regularly. Those that may benefit from antiviral treatment should either discuss this with their GP, who then may refer on to an S100 prescriber or a tertiary specialist. Next slide, please. Okay, so in terms of hepatocellular carcinoma surveillance, there is a certain cohort of people that should be monitored 6 monthly with ultrasound, with or without AFP, with those with chronic hepatitis B. So those people are people with cirrhosis. Anyone aged over the age of 40 with a family history of hepatocellular carcinoma first-degree relative, and then consider offering surveillance 10 years prior to the earliest case in their family. Those of sub-Saharan African people greater than 20 years of age, Aboriginal and Torres Strait Islander people greater than 50 years of age, and Aboriginal and Torres Strait Islander people with features greater than 40 years. With high-risk features with high-risk features if they are over the age of 40 years, Asian Pacific males over the age of 40 years, and Asian Pacific females over the age of 50 years. Next slide, please. So monitoring and treatment. So monitoring of those with chronic hepatitis B. So liver function tests every 6 months, and hepatitis B viral DNA every 12 months. And this is Medicare funded. So this determines if and when the disease phase has changed and when treatment may be indicated. So again, treatment is in phase 2 and phase 4. Hepatitis B E antigen positive viral hepatitis, so immune clearance, and hepatitis B E antigen negative viral hepatitis, so immune escape. And also treatment is for anyone with cirrhosis with detectable hepatitis B DNA, viral DNA. Next slide, please. So first-line treatments include entecavir and tenofovir. Patients will generally take 1 pill every day indefinitely. It is safe and well tolerated. Normally associated with no resistance. However, treatment is lifelong. Some of you may recognize tenofovir as one of the antivirals that we prescribe in PrEP as well. Next slide, please. Benefits of treatment. So normalization of abnormal liver function tests, so ALT. Sustained suppression of viral replication, conversion of hepatitis B E antigen seroconversion, and seroconversion of hepatitis B E antigen reduces risk of progression to cirrhosis and liver cancer. Now, there should be a distinction between hepatitis B E antigen and hepatitis B surface antigen. Hepatitis B surface antigen seroconversion is rare, and that is a marker for hepatitis B infection. Hepatitis B E antigen is an antigen that is present during hepatitis B infection. Next slide, please. Quiz question number 5. Should Chen be regularly screened for hepatocellular carcinoma? No, Asian men only need screening when they have cirrhosis, or B, yes, because he has a family history of hepatocellular carcinoma.
I think we're ready to launch the results.
Yes. Yes, so most of you answered B, which is correct. Yes, because he has a family history of hepatocellular carcinoma. Next slide, please.
And I think it goes to Tao.
Okay.
Okay, so the key points in treatment and monitoring is that all patients with chronic hepatitis B need to be monitored every 6 to 12 months. Not all patients with chronic hepatitis B require antiviral therapy. And antiviral therapy is targeted at patients in the E antigen positive chronic hepatitis B phase or the E antigen positive chronic hepatitis phase with high viral load and elevated liver tests. Entecavir and tenofovir are the first-line antiviral therapies. Accredited clinician can prescribe antiviral therapy in a community setting, and really GPs are essential in ensuring that at-risk patients with chronic hepatitis B undergo surveillance for liver cancer. Next slide, please. I think I might let Brendan discuss this one. What are some of the systems to support management of chronic hepatitis B in primary care?
Yep. So in terms of recalls and reminders, so depends on what your medical software is, but you can always set up automatic recalls and reminders for patients with chronic hepatitis B. If they do not need treatment, then as a baseline, they should have a liver function test every 6 months and a hepatitis B viral DNA every 12 months. Either you can set that up as an automatic SMS reminder, or you can get your practice nurse to call them and remind them to come in for their regular appointments. You can book follow-up appointments in advance to ensure that patients then will be sent reminders for their upcoming appointment and that they also attend. You can provide pathology and ultrasound requests forms early. Again, SMS, phone reminders, or even letters. Arrange interpreters and translated appointment details if required. Most importantly, follow up on missed appointments. You can, we use best practice. So if you set up an appointment as a recall, if you've booked it in advance, then a patient will be automatically sent a reminder if they have missed their appointment. And then the clinic can also maintain a register of chronic hepatitis B patients, and that can be managed by your nurse in order to ensure that patients come back for their follow-up appointments. Next slide, please. So there are Medicare service pathways to the management of patients with chronic hepatitis B. So Medicare is a minefield in itself, but there are several Medicare service pathways for the management of patients with chronic hepatitis B. It is important to stay up to date with these pathways as they are reviewed and changed frequently. So I guess common MBS items that you might use, so now called the GP Chronic Condition Management Plan, which used to be called the GPMP. Anyway, so item number 965 and 967. Item numbers 729, 735, 739, 743, they all pertain to case conferences. Item number 900 is your home medicines review. And then just be aware that on the MBS, there are item numbers that pertain to bloodborne viruses particularly, but they are only on telehealth, so phone or video, and depending on the length of the time that you discuss these. So the phone item numbers are 92731, so less than 5 minutes, 92734, 5 to 15 minutes, 92740, so 21 to 40 minutes, and then 92715, sorry, 92734, and then 92740, which is my understanding greater than 40 minutes. And then video item numbers, again, 92715, 92718, 92721, and 92724. And then all this information can be found on the MBS website as well. And next up, please.
I think it's Tao's slide.
Yeah, okay. So in case you're not aware, patients with chronic hepatitis B who are being considered for treatment or undergoing treatment are eligible for the Section 100 co-payment program. Basically, this means that New South Wales Health pays for the patient's co-payment for the antiviral therapy. And you're able to do this in a community pharmacy, not just in public hospitals. So there's a link for the co-payment for Section 100 and also prescribed with medical practitioners as well. Next slide.
So the first question was, if Hep B is mainly transmitted via sexual contact, parenteral and perinatal, why do household contacts need to be vaccinated if they are just living together and not having a sexual relationship?
Do you want me to take that question?
Oh, I'm just having a think about it. My understanding now is that they are still at risk of transmitting hepatitis B to household contacts. Obviously other ways other than sexually. So, like, if you're tending to, your household contact who might have a cut or something like that, there's still a risk that hepatitis B may be transmitted that way.
Yeah, that's true. The other reason why that we don't treat everyone, so the people highly infectious are actually in phase 1, where they have very high viral load but no immune activity. So you don't actually treat those people. So we may not know though, so those people are much higher risk for transmitting or passing on the hepatitis B infection. That's what we think is occurring in, say, for example, children to adolescents, how they might come into contact with hepatitis B in inadvertent contact. Would kissing, saliva be the cause of hepatitis B transmission? Is the next question.
Yes.
So I would say there's very, very small risk in terms of that. If you think back to the table in terms of infectiousness of body fluids, saliva is less than, say, blood or serum or vaginal semen. So no, I would say that the risk is low with kissing someone.
Tao, can we jump to, someone asked another question. They said, I don't understand why phase 1 doesn't require treatment when the viral load is higher than phase 2. Is it because there is liver derangement in phase 2? So if we have a patient who is in phase 1, we wait until they're in phase 2 before treating. So this kind of goes on to what you're saying before, that patients who are in phase 1 don't need treatment. My understanding is because their LFTs are not deranged, they're not at high risk of progressing to cirrhosis and hepatocellular carcinoma?
Yes, I mean, there's a lot of discussion actually whether certain people in immune tolerant or phase 1 should be treated actually. I suppose to keep it simply is that treatment is lifelong. So many people, once they start oral antiviral therapy, will remain lifelong. So the decision has been based on we will only start treating people when there is evidence that the chronic hepatitis B has started to cause some injury to the liver. And in our case, in phase 2, apart from just the high viral load, the ALT being raised, but if they've had a biopsy or they've had non-invasive investigation of stage 2 liver disease that suggests they're in phase, they're at stage F2 fibrosis, then you would consider treatment. However, you may have someone who is from a very high prevalent country who's now 40 years old. They're still in the immune tolerant or phase 1, phase. Would you treat that person? I probably would, because they're actually at risk already of having some damage to their liver. So there's a lot of controversy around that. And there's also a lot of discussion about simplifying the treatment of hepatitis B. Our rules are so complex, but WHO has actually put out a new guideline to try and simplify it. So there's still ongoing discussion with that. Okay, so at the moment, our guidelines haven't been updated, so we would not treat anyone in phase 1.
So going back to the beginning then, so does someone with resolved chronic hepatitis B, hepatitis B core antibody positive but negative hepatitis B surface antibody and antigen, are they immune for life, or can they be reactivated or reinfected?
Okay, Hepatitis B is not curable. Once you're infected, there is a chance of reactivation because the hepatitis virus is a DNA virus, and some of the virus DNA integrate into our DNA, the liver cell DNA. Even though they may have, in all intents and purposes, achieve a functional cure, which is where they have lost their surface antigen, they may have developed surface antibody, and we may consider stopping treatment. They are at risk of reactivation should they become immune suppressed. So, for example, undergoing chemotherapy or undergoing immune suppressive therapy where there's a high risk of suppression of the immune system. So we say there is always a risk. Yeah. And people who stop treatment should still remain in care, and that is with monitoring in case they do reactivate.
Okay. But the next question, if someone has had complete childhood hepatitis B vaccine, had serology showing immunity, but in later years, the hepatitis B surface antibody becomes negative, does the person need to get a booster vaccine, or is she immune for life?
Good question. Because you do actually, with time, the surface antibody does kind of wane and come down. But we say that anyone who had a surface antibody above 10, which is the level of detection with our current assay, we say that they will still be immune, even though they're 10 compared to someone who is still the surface antibody level is still 300. Okay. I suppose it's also a risk assessment for that person, how at risk they are in terms of reinfection, or if they were to get infected, how serious would it be for them? Yeah.
Is there a register for S100 prescribers? It's a good question.
I don't think there is. I don't think there is. Is there ASHM? Well, maybe through ASHM, because you do provide national education and courses. So maybe ASHM might have a national register.
Yeah, I think we have a map on our website. If you're willing to be on that map, you can, and we can also connect you to other prescribers.
Right, so the next question, if a patient has natural immunity through past hepatitis B infection, and if that patient has hepatomegaly with high AST, high ALT, and high GGT with a background of moderate steatohepatitis, should we investigate further?
I suspect that those results that you have just mentioned really reflect the steatohepatitis or the fatty liver. But I probably, at caution, would actually make sure I do a DNA level to see that there's no reactivation. But most likely those test results reflect the current fatty liver rather than hepatitis B reactivation.
I think this was more when I was talking, how often do we need to arrange for follow-up in terms of timeframes? Which was covered in what we were discussing, but essentially if you're a GP and the patient doesn't need treatment, so I guess we would say phase 1 and phase 3, then it would be a liver function test every 6 months, and then your hepatitis B viral DNA every 12 months.
I agree with that. And that's because the fact is that we only can order 1 viral load per year if they're not on treatment under Medicare. If you are on treatment, you're allowed for a year. So for us is looking at the liver test. If they start to rise, we need to assess why it's rising. Often there might be a reasonable cause such as acute infection, maybe antibiotic or drug related. So that prompts us to reassess and exclude all these other causes, then to consider checking the viral load to see if the hepatitis B is becoming active again. In my terms of my practice, once they start treatment, I check their viral load and liver test every 3 months until they become the viral load becomes undetectable, and then I would then go down to every 6 months. And if someone is undergoing liver cancer screening, I tend to link it up together. So my patient know that they come and they have they see me twice a year, or they have two lots of ultrasound and blood tests a year. So it might be March and then September. So it's easy for people to remember.
Okay, so the next one was, if a patient had the hepatitis B vaccine 3 doses and did not seroconvert, what is next?
I probably consider giving a booster. A booster vaccine. Some people, less than 5%, actually have no response at all to the booster as well, and so you might have to reconsider doing the whole course of vaccination again. Yeah.
Yep. And the next one was, for those patients who did have hepatitis B but completely cleared, can having things like chemo or immunotherapy bring hepatitis B back? Because I heard that hepatitis B DNA stays in the liver.
That's true. So if someone is going to become immunosuppressed, particularly undergoing chemotherapy, then they should start on the antiviral prophylaxis. So in particular, B cell depleting therapy, such as rituximab, the risk of reactivation is greater than 10%, which is very high. So those people should be consider prophylaxis before they start their chemo.
Yep. And what role does hepatitis B C antigen antibody have in determining the need to treat?
Simple answer, nothing at this stage, really. We wouldn't use the surface B C antigen. That test is not actually widely available. So, to keep it simple.
And a young person in their 30s with previous documented childhood hepatitis B vaccination noted to have anti-hepatitis B surface titer less than anti-HSB titer less than 10, asking for Hep B vaccination booster due to professional hazard. Does this person require booster vaccination? If yes, and how many doses?
Okay, with someone like that, I would probably reassess them to see if they've actually had natural hepatitis B infection. So I would actually do the serology and the viral load again, particularly if they are someone who's working in the dental or medical field where they're going to do exposure-prone procedures, because they would need to not have boosted vaccination. They actually need to be treated with it. Yeah, because some people will come, they don't remember the vaccination that they had, or they never were screened properly. Yeah.
Would you recommend routine ongoing liver ultrasounds in people with chronic hepatitis B or only in people that have deranged LFTs? When would you consider liver elastography?
Okay, so I always do a baseline ultrasound for a patient who's been diagnosed with hepatitis B, because I want to see the structure of the liver. I want to see if there's any signs of portal hypertension or cirrhosis on the ultrasound. You might see fatty liver, so they might then suggest to you that there might be a cofactor. And then I would then do the ultrasound, I suppose, if they a group that would need liver cancer screening with an ultrasound every 6 months. With regard to that, elastography liver elastography is looking at the stage of the disease. So you're trying to assess the fibrosis stage. Okay, and so there, yes, I do it for anyone with hepatitis B, a FibroScan, or you might have shear wave elastography, which is elastography that's done with a normal ultrasound. So a number of the radiology services offer this for free at the moment. So, for example, I think where I work, PRP will offer it, at Eastwood will offer it. They'll do a normal ultrasound, then they do an elastography study. They are not the same as the result for a FibroScan. They individually have their own threshold. So you need to read the interpretation from the radiology service as such. Yeah. And the other thing also is an ultrasound can tell you whether someone may have a liver lesion. Okay, where elastography doesn't. It's looking at for fibrosis and possibly the fibroscan with steatosis.
If we can do one last question, then we'll wrap it up. Thank you.
So the one at 828 was, should patients with isolated hepatitis B core antibody, negative hepatitis B surface antigen, and surface antibody be vaccinated?
It depends. I suppose we probably say no, you don't, but some people do consider offering of vaccination because of the risk to that person, so to speak. I think the final question is really a good one. If a patient has fatty liver, is the ALT threshold to treat still the same? Yes, we still leave it the same.
Thank you. Any one last comment, words to attendees?
I think screen everyone, don't make any assumptions, and say that there is actually good treatment available, where we can actually prevent some complications from the liver disease, including liver cancer.
Thank you.
I think from my perspective, as GPs, if a patient has chronic hepatitis B, not all those patients need to be referred to a specialist. Those in certain phases of their illness can be safely monitored by us. And when they need treatment is when we should refer either to a community S100 prescriber or a specialist or tertiary hospital specialist or something like that.
Thank you. That brings us to the end of the session, and I will just wanted to extend my thanks to Brendan and Tao for presenting, and also everyone who joined us online. We do hope you enjoy the session and you also enjoy the rest of your evening. Thank you, everyone.